Good to see everybody. Pleasure to have you. My name is Michael Stamatinos. I am the founder of the Advancing Healthcare Innovation Consortium and the host of the Advancing Healthcare Innovation Show. And we're going to be talking about innovating and equity and access and a whole bunch of things in this dynamic discussion. But before we dive in, let me just kind of tell you how this whole thing came about, because I think it's a really interesting story. Eric reached out to me and said, "Hey, what are you doing for Chicago Tech Week?" And I looked into it and said, well, there's really nothing's going on. And as I started to dig in and look and investigate this, there were things around life sciences and climate, and there was nothing around healthcare. And I got annoyed, and I thought, okay, we need to do something about this. So my initial inclination is, who am I going to reach out to? So I messaged Dr. Ezike and I said, hey, if you have a few minutes, I have a ridiculous idea and I want to run it by you. And it was this sort of vision. So I had a conversation with her, and her immediate reaction was, I love this. And then I dropped another thing on her, say, hey, we only have a few weeks to get this thing going, by the way. And her reply was, I have an amazing team, and we're going to do this. So here we are. This came about because he instigated it, and when you get to connect with unique dynamic leaders that want to innovate, and there is a difference between being interested in innovation and then committing to innovation. So there was a lot of orchestration and things that needed to happen, the herding of cats and schedules to make this thing happen, and that is very true about what it takes to innovate. You have to be nimble, you have to move quickly. So my motto in life is think big, start small, move quickly. And Sinai Chicago embodies that as well, because I have a history with this institution, and prior to doing what I'm doing now, I spent a bit of time with Hanger Clinic, and we had an embedded clinic here. And one of my colleagues is actually in the audience today, so we've been able to see care being delivered up close. Personally, I know that this place has soul. It has something that is hard to describe, but you feel it when you're here. So today, we have the opportunity to be able to highlight the innovations that aren't just happening in the future, but innovations that are happening today at Sinai. And what better place to do it than here at Sinai during Chicago Tech Week. So really excited about this conversation, because we have 4 dynamic leaders that we get to have a good conversation around. So here we have Heather Gray, who's the CEO of Elixir Trials, and we have Dr. Ngozi Ezike, who's the CEO of Sinai Chicago, and then we have Eric Alvarez, the CEO of Grapefruit Health, and then we have Melissa Gutierrez, who is the Director of Research for Sinai Urban Health Institute. So let's get going. Let me just take a second to just do a little bit of housekeeping. We want this to be a dynamic session. So for those that are in the studio audience, when you have questions, jot them down, then you can be able to come up. We have a section that we're going to have the interactive sessions. And then for those of you that are tuning in live, welcome. We're so glad that you guys are here. If you're in the chat, we have someone that's actually monitoring the chat. Type in where you're from, and also type in the questions. We'll make sure that we get those, and then we'll answer them accordingly in that time. So let's get going. So folks, when we talk about innovation in healthcare, what should we really be talking about? And why is access just as important as innovation in itself? Whoever wants to jump in first can jump in, and then we'll tag along.
Yeah, I think innovation in healthcare, I think there's a lot of ideas, and there's that old expression like ideas are cheap. A lot of people have these ideas. We have friends of ours that talk about wanting to start something or pursue something, and it kind of dies on the vine, or it kind of stays like an idea. I was on at a dinner. We recently were the recipients of a grant from the Illinois Voucher Program. It's an innovation grant, $75,000. And Tuesday night we're at a dinner, and we were asking about innovation in healthcare, and the similar question came up. And to me, ideas need like a testing ground. They need a place to incubate and try things, and we need partners who are going to say yes to those ideas. And on the same side, those organizations get flooded with ideas as well. And so I think a big part of innovation is getting ideas into some sort of format or enough progress forward that they can actually be tested and tried out to get them into scale and become real parts of the healthcare ecosystem. But it takes both sides of that. And so when I think about healthcare innovation, at least like a limiting factor, I think a lot of times is finding an organization that's willing to take a chance on you, get that innovation into scale and become a real solution.
I think innovation is key. We've got to keep evolving. We've got to keep getting better. We've got to keep finding new and better ways. But if it doesn't get everybody, then there are few people that will take advantage of that. And in terms of the health space, if there's a segment of the population that gets the benefits of innovation and another segment that none of that touches them, really the disparities in the health outcomes, in the progress of people just continues to get bigger. And given that Mount Sinai, that's exactly what we're about. Like, we are all in for health equity, and how do we bring up groups and communities that have traditionally had the worst health outcomes? How do we make sure that we are solving that gap and not just watching it grow? And so that access is almost as important as the innovation itself, if we care about all communities. And that's the question. That is the question, though.
I think, too, that when you're building innovations, the access is equally important. It's not even just about getting the innovations out when they're available to all communities. If we're actually building innovations and not including all communities in the process of clinical trials, in the process of AI building, in the process of advancements in healthcare, what we end up doing is bringing drugs or treatments or innovations in technology to the market that actually aren't applicable to everybody, because we haven't looked at how all communities will respond, and we haven't looked at the needs of all communities when it comes to those innovations. And so, to me, health equity and innovation are so deeply entwined, because to Dr. Ezike's point, you broaden the gap when you don't include all communities, but that starts all the way back at the beginning of building that innovation.
Can I just double click on that? Because I was just talking with my team, and in our meetings we usually have a health equity spotlight just to kind of ground the meeting, ground us in the work that we have to do. And I was presenting and I was sharing the example of just pulse oximetry. And with pulse oximetry, there are a lot of different companies that make the pulse, give you the O2 sat. And looking at the breadth of research that's out there, there are peer-reviewed studies that show that some of these machines are not accurate in darker pigmented people. And so if you are counting on this as one of the tools that you use to actually make clinical decisions, say, oh, you're doing better, oh, you're having a problem, and it's giving you higher numbers, and so therefore reassuring you that a patient is doing well, but it's not actually accurate, you're actually harming people. And as they look at why it is, it's like, oh, how the light comes in and how it's read. And there's acknowledgement that when these products were being calibrated and developed, they did not involve people of all different hues and skin colors and backgrounds, and so therefore it works for the groups that they tested it on. And so, to your point, if you don't test it on everyone, it's not effective for everyone. And in fact, in COVID, we had a lot of individuals, Black people specifically, who were hospitalized for COVID, were told, okay, you're good to go home, and then died 24 hours later, died 48 hours later. Again, because one of the tools that we were using to make clinical decisions was actually giving information that was not appropriate. And so just a real life example of how from very upstream, from the development, you need to include everybody. So whether it's for therapies, medical, therapeutics, whether it's equipment, we've got to include everybody.
Melissa, I want to kind of go to you, because oftentimes when it comes to the community and we're talking about them being hard to reach, what do we mean by that? And then how do you interpret that as an epidemiologist in the work that you're doing?
Yeah, that's, sort of going off this conversation right now is that, in research we often talk about, or we hear people say, oh, these patients are hard to reach. And I don't think that's true, right? Like, they aren't hard to reach. They're our patients, they're our community members, they're our neighbors, they are there and want to be a part of these. The problem is, you know, we talk about it, that's hard to reach, but who's the problem, right? The problem is the person doing the research, not the patients and the community members we're trying to work with. And one of the things that I've done some research on is this concept of trust versus trustworthiness. And so trust we can build in one-to-one relationships, but trustworthiness is our systems. And you know, historically, we've not always created these trustworthy systems, and I think Dr. Zike used a perfect example. And so we need, as systems, to build trustworthiness before we can build trust with patients. And when we bring innovations, when we start trials early on and bring community members to the table as a community advisory board or asking them their opinions, that's how we build trustworthiness. It's how we build trust. And then those patients aren't hard to reach. They want to be a part of what we're doing.
Example of that, when you talk about trustworthiness at scale, I think that maybe makes it a little bit more concrete for the audience.
Sure. I have this example, and it really changed the trajectory of my career, but we were doing an Westside Asthma home visiting program for pediatric patients, and one of my researchers was going out to do a data collection visit. As an epidemiologist, I really like my data. And she came back and told me that she didn't collect the data, but that she scheduled another appointment. And I asked her what happened. She said she got there and that the mom was going through some really tough times and needed to talk to her about it, and she was struggling. And so, you know, Miss Kim sat there and she listened, and she was there for an hour and a half. And she came back, but she was able to schedule that data collection visit. And the data means something to me, but her child had improved asthma. She actually quit smoking. And like, those are the things that make a difference. And that's, you know, for me, how we show up and build trust. And when we represent systems, we build trustworthiness with our community. So, thanks.
Eric, I'm curious because you, from the innovator standpoint, when you're thinking about building, how much of trust and trustworthiness goes into the build, into the solution? Talk through that. Is this something new that you've kind of encountered? And I'm just curious how you've reacted to that.
Yeah, I think when we started, you know, we apply the guest test, iterate model, and we didn't focus on that maybe as much in the beginning. So Grapefruit Health, what we do is we employ about 500 clinical students who perform patient engagement telephonically. And what we realized overall that these over 1 million engagements now is that we can match our students to patients based off language, culture, proximity. And when that patient hears the same accent on the phone and the student already understands those SDOH issues, trust is made dramatically faster. Like we have a client, for example, in Eastern Tennessee, coal miner area. A lot of these folks still work in the coals, et cetera. And when a guy with a Chicago accent calls that patient, that conversation feels almost dead, right? Like there's already like a wariness or what's going on. What are you trying to sell me? When our students sound exactly like and look exactly like our patients, again, it develops a lot of trust, and I think the research supports that. So hypothesis in the beginning was not that. We just thought any student from anywhere, we'll call whoever we need to. And through learning that and watching our reach rates go up and our conversion rates on whatever the task is, and then the length of the conversation actually increases dramatically as well when you match a student to a patient based off all of those variables. So it's become critical to our success, and honestly, it's one of our strongest sales points. Our clients actually, they believe us when we say it because they've read that and they've done that research as well.
What about you and what you're doing, Heather?
Yes.
How does that impact? You know, because a lot of people are left out of these clinical trials, and so when you're thinking about this, I'm just curious, like, run us through that.
Yeah, I think that when it comes to clinical trials, the infrastructure of clinical research was not built for patients. It was built for research. It was built for ease of research. 88% of hospitals in the US cannot perform clinical trials today because the innovations are all focused on those 12% large research facilities. And I think a big part of that problem that we face in bringing that out to the community is trust. That's number one in my opinion. But number two is the infrastructure itself. How do we bring this to community hospitals, allow community hospitals to run clinical trials? And do it differently and do it in their own way, right? They're not going to do it the same way that a large research facility does it, but that doesn't mean they're doing it wrong. That doesn't mean the data quality is poor. That doesn't mean patients won't adhere to the trial. What it means is that we need to build the trial to be successful in the community. We need to look at aspects like, what do patients need to participate in the trials? Do they need transportation? Do they need childcare? Can we do telehealth? Can we do remote blood draws? All of the things that we can look at to make clinical research more accessible to communities is an infrastructure build. And so at Elixir Trials, that's what we're doing. We are building the full clinical trial infrastructure from 0 to 100%. If you're not solving 100% of the problem, you are solving 0%. You cannot solve the regulatory only, or the patient matching only, or patient awareness only. You have to solve every aspect, from how the hospital runs the trial, to how the patients learn about the trial, to how the patients trust participation in the trial, and then to how patients stay on a trial.
Dr. Ezeki, I want to kind of tap into that, because as a safety net institution, you guys have been around for 100 years, so there's a lot of connectivity between what you guys are doing with the community. When did you sort of decide, or what were some of the contributing factors for you to say, hey, you know what, we need to be doing these types of clinical trials here? Talk us through that and what was going on.
Yeah, so we've always been the place of health equity. It was founded because back then, 107 years ago, Jewish patients didn't have a place where they could get culturally competent care. Jewish doctors didn't have a place that they were allowed to practice. So obviously the communities have changed. We're now largely African American and Latino, but we still have some of the same issues where some of these patients, by virtue of maybe what kind of insurance they have, are not welcome everywhere. And so we are still on that mission that everyone deserves the access to health care. It doesn't matter what kind of insurance. Like, health care should be a right and not a privilege for some. And so following that, extending that, it means that we need access to everything, right? And so why you have health care, and we're trying to do the best with the fewest resources, we also have rehabilitative services. That's on the continuum of care, making sure that they have access. We're the only hospital that provides all of the rehab services for all kinds of Medicaid insurance. But that's another frontier, having access to additional, maybe not yet FDA approved therapeutics, so that you're not saying, oh, these medicines didn't work, sorry, we did what we could. When other people in the same condition, they'll say, but we could offer you this trial and see if this works. We need that for our patients too. And so being able to do that, I'm proud to be the first physician to ever lead this institution. And so there's a responsibility with that to make sure that we are, taking advantage of my medical background, my clinical expertise, and understanding, like, what are the other frontiers we should be leading. And we've been dabbling in it, but I think we need to establish this place, given the large numbers of people that we serve, given the communities that we serve. We need to go deep and say, hey world, we are here. We have the patient population that has been desperately and forever overlooked. We are ready to engage. We have physicians that care about science, care about patients, that are willing to be principal investigators. Let's go. And I have had nothing but support from all the physicians, from all the operators that think this is fantastic. The community actually will have still some reservations because the trustworthiness has not always been there, and when they think of clinical trials and research. And I remember in COVID how much I heard, but what about Tuskegee? But what about Tuskegee? And so there's still some reparative work that has to be done to build that trustworthiness and make sure that people understand why this is a benefit for all.
Heather, when you think about trustworthiness, do you sort of give it a timeline? When do you know that you've actually achieved trustworthiness? Are there signals? What do those signals look like? How do you measure those things?
That is a really good question. So I think completion is our measure, right? So there's often a lot of people start trials, but it's whether or not they finish studies. So that's sort of the ultimate goal and one way to show success or that someone develops trust. I think it's when people are showing up, right? So I always talk about this when we talk about how to engage communities and what building trust is that it isn't just developing a community advisory board, which is often every study we do, we have a community advisory board, and we get the...
comprised of?
Oh, great question. So I'll give an example. We have a large study called Empower Your Voice. It's around female identified well-being in the city of Chicago. And that is made up of various leaders that lead community, girl-serving community-based organizations. We have someone from Chicago Department of Public Health, Chicago Public Schools, and we have community members, so moms of daughters, and we have a whole youth advisory group because that's who we're enrolling, not just their parents. But I would say one of the things, and I was talking to a colleague on the way into work, is that we can't just ask people to come to our advisory board meeting or our trial. We have to show up for them. And so we did a large study at the Sinai Urban Health Institute, and we had an advisory board, and there was a pastor, and he called me one day. This was back when we all came to the office and we had phones, not cell phones. I picked up and he said, "Melissa." "Yes, Reverend Smith?" He's like, "I always come to your things, and you have never come to my church." I said, "You're right, I haven't." And so on Sunday, we brought our families, and we went and heard Reverend Smith preach. But like, it takes time, and you have to show up for them just as much as you're asking them to show up for us. And that's how I think you find success. It might not be in the eyes of the community. It might be in what are we doing? How are we showing up? That's one way to think about it.
Can I get an amen?
Yeah, Reverend Smith.
Yeah, it's like human beings that work a lot like a bank account.
Yeah.
When you open up a bank account, you need to deposit into it. You can't just immediately go and just start making these big withdrawals. You don't have enough in there to substantiate the withdrawal, but you got to make those deposits. So now knowing this, if you were to sort of go back and if you had to completely reimagine the clinical trial, knowing this, taking trustworthiness into consideration, maybe let's workshop this right now. What does that look like? You know, we don't have any safety ropes here. We're doing this without a safety net, even though this is a safety net hospital. Huh?
Good word correlation.
Talk me through that.
Designing the research space from the very beginning and, starting from scratch, instead of designing it with the sole purpose of getting an innovation into the market, I believe it should have been designed and should be redesigned with the sole intention of including all patients in whatever innovations are being created, in helping patients with not just receiving that one innovation, but all of their world around that. If a patient needs an innovation, they likely have some pretty big things going on in their life.
Right.
And we're not addressing all of that as a whole for a patient when we go into a community and we just say, "Hey, I have this drug, it's great, try it." There's no education there, there's no support there. And so
it's super transactional.
That's right. And that's how research is today. It's this list of available trials that a patient may match to, and let's present this list of trials when the patient qualifies and see if they're interested. But what about all the trust building, and what about all the other aspects that patient needs help with for everything else going on in their life? None of that is there. And that's why community hospitals are just so perfectly poised for this revolution in clinical research, because community hospitals have led the charge in making sure their patients are taken care of. Community hospitals have led the charge in thinking of different ways that they can support the patients, the communities, interacting with community leaders, and actually integrating within the population that they serve versus being the large, shining, shiny beacon that a person goes to when there's no other choice. And so I think that's how we redesign it, and how, if I was redesigning it from the beginning, I would start in the community. That's where the patients are. That's who needs help. You start in the community.
I'm having such an aha moment as you're saying this, because I know that we are going to start getting deep into this. And so what are we waiting for to already start having those community groups talking about what this means, what we're thinking about, how they feel about it. Like, we could be doing the foundational work already, and we will. And we'll do it with SUI, and we'll do it with our Community Institute. But really, like, the time is now to bring up this topic. Since we know we'd like to head in this direction, we should be engaging the community now to say, hey, this is what we're thinking. How does this hit you? What would it take to make this successful? What would it take to reduce whatever barriers that what would make you not want to participate? So we have some work to do.
We have some work to do.
We have some work to do.
Yes.
Eric, where do you see Grapefruit Health, fitting into that picture, knowing with some of the work that you're already doing? Can you maybe shine a light on that for us?
Yeah, I think, when you think about building a trustworthiness organization or initiative, there's like the top down and then the bottom up. And so the top down maybe is like how the organization is perceived, and then maybe one layer below that, it's like going out to the community, as you mentioned. But to talk to patients one-on-one is challenge. There's like a scale issue there, right? So you might start with like a community leader, convince them of your trustworthiness and build that relationship, and then let that trickle down and come through it. I think for Grapefruit Health, we are only human, and we are only one-to-one. And so as conversations around this, we're in contracting right now with a large national lab, and it is similar to that. So these patients have been identified as qualifying for these trials, and some of the work we're going to be doing is helping them build that trust across, but it's very one-to-one. So we're not the organization that's going to build the relationship at the top-down level. That's not where we operate, but that's how we think about it. Is we're going to be the one-to-one scale portion.
Curious, Melissa, again, what do you think needs to happen in order for you guys to consider that a trial is worth kind of really moving into from a community? How do you assess the needs of the community?
That's a great question. So I think, Dr. Zike, it's on my list to do some focus groups and interviews with communities, and we plan to create a clinical trial community advisory board, which is really exciting. I don't know. I guess I toss it back to other folks.
Yeah, their groups, she's maybe being bashful, like, she helps lead the community health needs assessment for our communities, many communities all throughout the city. She gives us the report that shows, here are the things that the communities say they want, here are the needs based on the metrics that are out there from, all the things, whether it's health metrics, whether it's economic metrics, all these parameters. So that identifies what clear needs are, both in terms of health metrics, in terms of what the community says they want. And so really being aligned with that is a great place to start. If the community is saying, we are having, I think one of the things that definitely came out in this year's was behavioral health, so we know there's an opportunity in behavioral health. And so just looking at the research that you've already done, guided by community, we can know what's on their hearts and be able to align that with the things that are clear, medical needs for our communities.
When you're thinking about a great partner, because oftentimes the partner to me is an extension of Sinai, what are some of the non-negotiables that need to be in place for someone to be a great partner for Sinai? Because Eric, you mentioned about some of the needs that an emerging company needs to have, but what does Sinai need to have in order for someone to be a great partner?
Yeah, I think we have to have mission alignment. I get it, science, innovation, it's a business, but to do business with us, there needs to be mission alignment, because if we're not on the same page in terms of why this is so important to us and how deeply seeded this is for us in terms of making sure our patients don't continue to be left behind, and it's just for people with money aspirations, like I think there won't be alignment. And I think when it comes down to identifying the specific needs that our population needs, those will be things that people will just see as, oh, you're cutting into my profits, right? And not saying like, oh, great, that's what we need to help make this successful for your patient population. So mission alignment, I think, is number 1, 2, and 3. If I try to get down to 4, sometimes I think like, have you been successful in this before? But that can sometimes be a high bar, because I know a lot of people have not worked with organizations like us. They've not worked in community. We know that. That's a given. So, trying to understand, what are some other things that we could look at that would suggest that they would be successful with a group like this, with our populations, is important. I'm not sure how else besides previous track record to assess that, but there's probably some intangibles that could come up in those discussions.
Yeah. Eric, talk about your exposure to Sinai. I know that they were an early client of yours. Talk through that experience, what was learned, and then if you had to kind of go back and do it again, would you do anything differently?
Great question. As an organization, we're 4.5 years old, and we are forever grateful for Sinai Urban Health Institute and the greater Sinai environment. So we were looking for a partner to try what we were doing. We kind of self-funded this little pilot. We were very, very much in senior isolation and loneliness. We were trying to match students to isolated seniors. And when we got introduced to SUI, we said, look, we can do this thing. Look, we really don't have funding for that, but can you help us enroll patients into diabetes prevention programs? And then now we're getting into this Medicaid redetermination and re-enrollment work that we're doing across Medical Home Network, et cetera. And we didn't know what we were doing back then. And so for an organization to say yes, I think we came off very confident. So to your point, I think that is one of the measures that healthcare organizations look at startups and early stage innovation. They say,
you were an operator.
I used to run service lines, and I ran a successful startup before that, but this was our first time at Grapefruit Health. And so they really gave us an opportunity, and once you have that traction, you can go to investors and you can go to other organizations and say, look at this case study and look what we can do, and that's really get started. So I don't know if I would do anything different. I maybe just talked to Sinai a little bit earlier. But what an appetite for innovation this organization has. When we approach other organizations like Northwestern that have dramatically different margins and different populations, the answer has always been no. So I think it's actually an interesting thing. We talk sometimes about underserved organizations or safety net organizations not having the resources to pursue innovation, but that wasn't our experience whatsoever. And we've had more success on the access side and the safety net side than we've had in these, Cleveland Clinic-y things. Yeah.
And I think something about that is we're talking about innovation, but Sinai is super innovative already.
Very.
Even with the technology that we already have and what we're bringing to our patients, and I don't know, Dr. Zike, there was some mentioned at the town hall 2 days ago or something, and I don't know if you want to talk about any of those or.
We have lots of innovation. We are one of only 3 institutions in the state of Illinois that have the certification, the center, the designation of excellence for minimally invasive gynecologic surgery. We were the first hospital in the country to do a pediatric gallbladder surgery using the Senhance, a special, kind of almost robotic device. First in the country, that surgery was done here at Sinai. So, I think, in fact, we were the only institution to have both the Senhance and the Da Vinci robot. So we
so cool.
Small but mighty. But mighty is Sinai, doing great things, and we want to just build on that. We absolutely want to build on that.
Yeah, there's a sense of, hey, we want to innovate, but in your case, it's we don't really have another choice. We're in the sandbox, and we have these constraints, and the only way to really optimize within these constraints is to innovate. Is that sort of someone can view it as a competitive advantage, but there are other things that maybe aren't as a heading.
It could be
but
a blessing or a curse,
yes,
for sure.
There's trade-offs.
Blessing
There's trade-offs.
or curse. I mean, you've got it. We're scrappy, right? Some of the innovation in COVID, like we have these glass doors on some of the ICU rooms, and it wasn't that, we had the construction company come in, like, our in-house, facilities team, we're trying to find a way to not have people go in and out of the room so much when you had, a patient that was exposed. So they, kind of retrofitted these doors with see-through so that, you could kind of visually see what's going on and only go in when you had to. So that it was just like a real-time, on the spot, this is a need, how are we going to solve it? And then people kind of putting their heads together and making it happen. And I think because we are a smaller institution than maybe some of the big academic, behemoths, we can do things faster. You talked about being nimble, and I'm always. I think we were just talking about Gumby, and we have to stay Gumby and be. Well, I don't know if you're old enough.
I know Gumby. I know Gumby. I know Pokey. I'm with you.
And so really, and I've had a lot of people come to us and say, I have this idea. I'm bringing it to you because if I try to take it to somewhere else, they have all these levels and layers of red tape, and it might take 5 years, but I know you guys are willing to move and able to move. So yeah, there are definitely pluses to being a little bit more resource limited in terms of the hunger it gives you, the scrappiness you have to have, the nimbleness. There's some downsides too, and we'd love to have a few more resources, but we're making lemonade out of lemons.
Yeah.
Heather, curious about your take on AI. There's a lot of talk around it. How do you sort of safely infuse AI into the clinical trials process without leaving anyone behind?
So first and foremost, AI is happening, right? So I'm just saying that out loud. People are scared of it. Everyone has different opinions on it, but it is happening, no matter how each of us individually feels about it. And so taking AI and using it is not an option. You have to incorporate some form of technology if you want to keep innovating. That is how you innovate today. I think the difference is that AI or technology, simply for the sake of AI or technology, is where we fail patients. We need to make sure that our AI, our technology builds, are taking things off the plates of our providers so that they can spend more time with patients, so that patients can have a more human-to-human interaction. AI should not be the healthcare interaction. AI shouldn't be seen. AI shouldn't be felt, AI shouldn't be heard. What AI should do is make a patient feel like, when I come to Sinai, I see my doctor and I spend way more time with my doctor, with him or her, than I used to. And I notice that the nurses are spending more time with me, and that the staff has, the ability to answer my questions faster. And all of the sort of impetus behind those things is AI. AI taking all the back office workflows, AI for clinical trials, managing all of the tedious, work that today is done in Excel spreadsheets and, by clinical research coordinators manually, and, binders that are kept at a hospital. That can't be the way that we run research and allow places like Sinai to take on more and more and more clinical trials and build trust with patients to participate, because they're getting that face time with physicians and nurses and research coordinators. And then one more thing to add to that is that doing everything manually today means that all of that information lives only in that institution. And that is actually how we get to health inequities, is by information and data and important knowledge staying in one institution. And so building technology that allows innovation and research, information, data, knowledge to be shared with the world, that is how we get to better health access for everyone.
I think, so AI is inevitable. I also think it's great, within reason. And we're already seeing it widening these gaps, right? It's, in social epidemiology, we call it the inverse equity hypothesis. But, mammography machines are a great example. So first there were digital mammography, and then 3D mammography, and Sinai has those, and we've actually had a 3D mammography machine for quite some time. But now we're seeing AI and mammography, and we might see that gap that we narrowed between Black and white mortality rates widen again. And so, we have to, as a hospital, as a community, or as a community hospital who's serving a community in need that's been left behind, move forward with the times as well and bring those innovations. And Heather, that is one of the reasons I'm super excited to work with Elixir, is that there are a lot of drug companies out there that would love to work with Sinai patients, but Elixir's showing up with the right reasons, right? And Dr. Zike, you are leading this institution with the right reasons to improve health and narrow those disparities, not just to enroll patients to meet target numbers. And I think that is super cool, and I'm super excited about it.
What makes the digital tool trustworthy?
Oh gosh. So it is my hope to go into some research is to find out how communities feel about AI and what it means, what do they know, what does it look like to them, because that's really, it's not available in the lit yet, so sounds like I've got a dissertation, a second.
Eric, because you've been very diligent about keeping the human in the loop, can you talk about maybe some of your rationale, how you're balancing both out in the day-to-day and where you see sort of the future going?
Yeah, I think broadly, there's a speed to innovation in healthcare for a good reason. It's naturally throttled by procurement, and then people go really fast, and then something breaks, and then there's a lot of regulations that come out to address that break and those types of things. And so when Grapefruit Health pursues organizations and we say we're human to human, you can see a relief because they get it. Our solution is very intuitive, and so they go, oh gosh, you're not another, and there's no offense here, but there's you're not another AI company pitching us today, because they were getting pitched by so many, so they're you can come in. The other thing that these organizations have done now to kind of throttle some of this innovation and try to do it in a responsible way is they've built all these review committees. And so we were pitching to a very large payer on the West Coast that we're in contracting with, and with the executive team, they said, if you were an AI company, we would have to end the conversation here, put you into procurement, you'd have to go through our safety, efficacy, and ethics separate committees. Each one, they meet only once a month, and you have to go through pitch, and they review your submission. It's about a 15-month process right now. So strategically, and our investors support us in this, is we're going to not pursue that. Now, we are using AI today to help train our students. So we've built AI patients off of some of our conversations. The students can now safely call an AI patient and practice things like handling suicidal ideation, or how to speak to an ESL patient, or dementia, or how to practice motivational interviewing, and all these other really cool clinical things they can do in a safe, no-risk environment. But it's a separate environment. It doesn't touch our clients' data. And so we're able to still experiment and build and get all these kind of efficiencies with AI without changing our business model. So that's how we've navigated it.
I want to say one quick thing. So this is just an analogy here, but my youngest worked at a pizza restaurant, and the sign on the door said, "We are not a pizza place, we are a people place." And I love that, and it always stuck with me. And so I think as we are building AI and we're building innovations in healthcare, we can't be an AI place, we have to be a patient place. And that means that all the AI we build needs to be to the benefit of patients. And again, like I said it, you said it perfectly, it's important, but just being an AI company today is not what the industry needs, it's not what people need.
Right. Yeah, and you'll notice a lot of these pure AI companies too are not run by healthcare people. And so
Right.
they want to apply their solution to healthcare, but they're not doing it in the lens of healthcare. And there's a lot of like businesses like finance or climate or others that human is not at the center of, and they think it's the same thing, and it's just not.
Yeah, I mean, we
it's
have to
definitely not.
understand that, AI is just a tool and how you use it. And there's one thing if you're using it to help make sweaters
Right, yeah,
faster,
right.
but it's another thing when you're dealing with making the brake systems for a car or doing something regarding health where there's a human life on the other end that could be lost because we're not being intentional. If the sweater, and you have holes in it and you wear a sweater and there's a gaping hole, too bad, so sad, but
Right.
not, much more dire consequences when you're dealing with healthcare or something like making brakes on a car. And so having that sensitivity and understanding that should dictate the extreme thought and intentionality and speed, not trying to just be out there, okay, we're going to get this out in 10 days no matter what, and you have not taken the appropriate time because you're just working on speed. Like, that's not good.
Well, you mentioned about just, being a physician, stewarding this organization well. What are some of the guardrails that you're thinking about having in place, making sure that before AI kind of folks that are trying to get into these underserved communities, what are the guardrails that you're trying to build and think about before deploying these?
Yeah, I think one of the key things is, not just having a tool or AI or otherwise just for the tool's sake, because it's a cool thing to have. Like, we have a list of challenges that exist that are real, and we need to be identifying solutions to address these challenges that will help elevate the quality, that will make our caregivers' life easier and better and make them more productive. And so if we're bringing something that's not addressing some of the things that we've already established, our pain points or things that we need to fix, then we're actually wasting our time right now and not focusing on what our priorities. Because there are lots of shiny things all over, and if you're just like, oh, that's cool, and I'm like flooded with all of these offers and opportunities, and please look here, look there. We really have to be laser focused on what do we actually need. And then find the organizations or the tools that can address specifically what Sinai needs.
Yeah, I've been seeing this lately. I call it like the AI treadmill. It's like, hey, we're going to do this, and you're on this treadmill, and you feel like you're moving. And it's like, this feels pretty good.
Yeah.
But it's like, hey, we're on a treadmill, but we're really not making any progress. So let's not mistake busyness for actually making progress.
Yeah.
That's good.
Okay. Thinking about this, you mentioned something earlier, Eric, about testing, building, testing, measuring, learning. I'm curious, Melissa, as it pertains to continuously learning from the community, what does that data collection look like? Is it in person? Are they surveys? Like, how do you actually make that something that is very easily accessible?
Yeah, well, I think it depends on the methodology, research methodology that you are employing, if you want to get technical. But we do a host of things. So we do a lot of surveying, like man on the street kind of, or person on the street. We do send surveys. We can send them via text message that people answer. We do a lot of focus groups. We have started to get into some really cool, innovative ways of collecting data. And one thing that we did was called data walks. And so one of the things that's really important to us is not just collecting data, but disseminating. And I'm going to push us a lot on that, is when we find the findings from trials, that it goes out in ways that community members can understand. For me, it's important to publish things in academic journals, but it's even more important to get that stuff out. So we did a really cool thing called data walks, where we took the data from our survey, we put it up on boards around a room, and then we had young women as well as stakeholders and people from the community come around and look at the data and tell us about it. Tell us their reflections. Do they see themselves in it? Did it reflect them? What should we do different? What else do they want to know? And that's a super interesting way of both collecting data right? That was really informative, and we took it and made revisions, but also getting that information out to people and disseminating, and I think that is critical. And going back, like, that circle is how you build trust, right? You ask someone to participate in something, their family got invested in it, we owe them that data, not their data, but like that information in a way that they can understand it.
It's that insight.
Yes.
It's like that insight. It's like a drug.
Yeah.
You want it to be able to get that, to close the loop. I know that we're running up close to time, and we want to be able to take questions from the audience. If someone does have a question in the audience, they can come up here, they can ask the question, and then we can address it. But before we do that, I just want to say that Chicago has every ingredient necessary to become a world-class healthcare ecosystem. We have great academic institutions, we have amazing providers, we have incredible researchers, Melissa being one of them. We also have investors, and we also have community leaders, all of which are comprised in this room today. So it's not, it's by design in terms of the studio audience, so you're here for a reason. So make sure you hang out, you talk to folks, and you connect and you collaborate. That's how things happen. Innovation happens in small rooms that are safe, that allow us to have real conversations with real people to move things ahead. So maybe we'll pause there, we'll take some questions. If anyone has a question, we can address those, or we can move on. Yes. Come on up. So state your name and the question, and then I'll repeat it so people on the live feed can hear it.
Hi everyone, my name is Ahmed Isola. I'm with Create Health Ventures. We are an early stage venture fund focused on digital health and tech-enabled services. So my question to the panel is, looking at clinical trials in particular, that historically has been one of the big challenges for the underserved populations, just getting access to that, or even just being aware of it in the first place. Heather, we've talked about the last mile piece, which is really challenging. So even once you get a patient matched to a clinical trial, that last part of just getting them enrolled is so complex. Oftentimes it really involves a lot of intervention to get it done properly and successfully. But my question is, even before we get to that point, if you look at the underserved population, there is a general mistrust of using the healthcare system, and I would imagine clinical trials falls underneath that. What was your outreach like to even let people know, hey, we are doing this here at Sinai. You can trust this process. It's something you should consider. So it's more about the outreach before everything else is even falling into place. Like, what does that outreach actually look like?
Before the panel answers the question, so this is Ahmed Isola from Create Health Ventures, and his question was really pertaining to the onboarding process and what are some of the mechanisms that are being used today to do targeted outreach to folks for them to successfully enroll in the clinical trial. Whoever wants to take that, go ahead.
So I'm just going to confess, that we have a lot of work to do and that we have not done that work. And like I said, that aha moment hit me on the stage that we have not started our clinical trials community advisory panel, but it will happen. So there are a lot of steps that still need to happen that I think we have to have that comprehensive plan that we're going to work with our Community Institute and our and SUI to make that happen.
And on that part of Elixir Trials, we do have some outreach done with community leaders in Chicago. I'm based in Chicago. This is my home. This is where I always wanted to start, and Sinai graciously has been that place that we are starting this. But we will have the community events and the community leaders involved with Sinai for their specific community to do things like distributing patient education, creating patient awareness through social media campaigns. Even Dan and I have conversations, and there will be media ways that we reach out to people in this community through the media for that. So I just want to make it very very clear that we will not ever launch anything with Sinai, in collaboration with Sinai as Elixir Trials, without the support of everything that Sinai does with their patients. These are their patients. You guys know what's best for your community. You lead the way and guide us in that direction. But Elixir Trials is there to offer our full support and backing to creating and distributing and being a part of building that community awareness.
Quickly add, and I know there's another question, but so Sinai employs a large number of community health workers, and these are individuals from the community, so the communities we serve, that we train to help navigate individuals through the healthcare system or help them manage one of their chronic conditions, just a few things they might do. But that workforce is ready to go, right? Like, they're in the community. So that's another thing, like, this is hard work. I have done a lot of recruitment and trials, and it is hard work. If anyone tells you different, they're lying. But I know that Sinai can be successful, and I think one of the reasons it can be successful is that we've got a lot of boots on the ground already, and it's really important. But it's hard work. So in a year, I'm still going to tell you it's hard work.
Hi, good morning. My name is Nelson Lee. I'm a Chief Medical Officer for a delivery company. First of all, thank you for the panel. This has been so inspiring, and thank you for your mission. My question is around data, right? When you think about innovation, and especially technology innovation, one of the key dependencies is data. And I think in communities of color, not only is there health disparity, there's data disparity as well. So I'm curious from your perspective, and how are we closing the data disparity gap to ensure that innovation is usually using robust data sets of all people, of all communities?
Okay, so that was Dr. Nelson Lee, a Chief Medical Officer. His question was pertaining to data sets, disparities, and what's being done to ensure that safely.
You want me to start? Yeah, great. So first of all, clinical trial data, I will speak to that part first. There are many data aspects, different data sets that we can talk to. But from a clinical trials perspective, this is the reason why it is important to bring clinical trial infrastructure into communities. The data today for research is only applicable to the patients of 12% of the hospitals in the US. And those patients don't live in the same communities that small community hospitals serve. And their day-to-day doesn't look the same, and their environment is different, and family situations may be different, and cultures are different. And the truth is that even, metabolisms are different. And so we're essentially creating today these data sets of small groups of patients without any heterogeneity. And that means that we don't know how certain innovations, how certain treatments will respond or will react in certain patient populations. The only way to fix that, the only way to get the data from all populations is to build that infrastructure for that data collection in community resources, community hospitals, community physician clinics, community pharmacies, right? We need to be able to build the data access points in communities. Otherwise, we only will continue to see the 12% contributing.
Yeah, and I think for us, a lot of our data is like demographic and reach data, like accurate phone numbers and addresses and this, baseline critical data you need if you can't even reach these patients, whether it's a mailer or contact information. So with Grapefruit Health, especially when we're doing things like Medicaid, eligibility or re-enrollment, we're doing all sorts of different tips and tricks just to get people to answer the phone. But once they answer, we're doing skip tracing, and somebody else answers the phone that says they're not there anymore, or this thing has happened. And so we're able to gather and collect data in a very nuanced, very white glove type way, and it enriches the data set so then we can actually do our job. And a lot of our clients and organizations that work with us, sometimes that is the work. Like they desperately need that to even power whatever they're going to use, even if they choose to use an AI solution. That AI solution doesn't have good contact information, it can't do its job. And so little less clinical type information, but we're gathering the stuff we need. And we could do this too for like health equity assessments or health risk assessments and CAP surveys and SDOH surveys and the likes.
But to your point, I don't think it's just clinical. I think you're right. Like, I deal with the clinical trial data. There are so many different data sets out there that are important that have to be, collected. And so every company that is working in communities to collect data, that together creates the bigger picture, not just clinical data or, consumer data. It's everything all together, and that's what we have to bring to communities.
Yeah, exactly. And then underserved populations, within the region can tend to be like very transient. So it's, tracking all that down. So like the data goes bad quickly, the accuracy of it. So constant check-ins.
Yep.
Yeah.
So we're going to start to wind down now, but before I forget, I want each of you to kind of just say, where can people follow your work? Maybe kind of give a little shout out so that people can kind of follow. I think that would be good. And then I have one last question for Dr. Ezike.
ElixirTrials.com is our website. We are on LinkedIn, Instagram, Facebook. I have kids, so we have a social media. We have a social media presence. My email is heather@elixirtrials.com. And we'd love to give you a demo of our platform, Cauldron, which is the operating system in the background of all of the people who do the amazing clinical trial work that we bring in. Or we'd love to just talk and figure out how we can help bring clinical trials to your community.
Great.
Ngozi Ezike, we are here at SinaiChicago.org. We are here to stay, and we are looking for partners that want to partner with us, so please reach out. I think we're on all the channels as well, and looking for the right partners to take our communities and their health and lifespan to the next level.
Yeah. And for Grapefruit Health, our website is grapefruit.health. It is .health is the domain. Sometimes people get that off, but we're also on LinkedIn, big presence on LinkedIn. Eric Alvarez, I'm on LinkedIn. And if you're a clinical student and looking for work, nursing, social work, pharmacy, pre-med, dietitian, OT, PT, is it anybody on a clinical path, please apply it. Yeah, grapefruit.health.
Great, thanks. And my name is Melissa Gutierrez-Kapheim. I'm with the Sinai Urban Health Institute here at Sinai as well. You can find us on Sinai Urban Health Institute out of part of Sinai Chicago, and then we also have a big LinkedIn presence. And some of the work that we do that I think might be of interest to many of you is we do a lot of needs assessments, or understanding people's health needs and what they're going through and what's of interest. And we do a lot of work around community health workers, and we also do have a large evaluation portfolio. And I have a really long last name, but it's melissa.gutierrez-kapheim@sinai.org.
And just before I forget, just a nice shout out to the Sinai team, which has been unreasonably hospitable throughout this whole entire process. Dan, KJ, Olivia, everyone has been really remarkable. Thank you so much for your hospitality, for putting this thing together, and just for being very, very gracious. It's just very evident that the ethos of Sinai permeates throughout every single person that I've interacted with at the organization. So a very big thank you. So for those of you that tuned in on the live cast, thank you so much for your time and your attention, and we'll see you on the next one. Thanks so much.
All right.